Hi, I'm Dr. Kenneth Qiu. I was chair of the Member Insights Committee that put this report together.
I'm Rebekah Bernard. I'm a member on the committee that helped to design this survey.
I'm Dr. Emily O'Rourke, and I was also a member of the committee.
I'm Dr. Kelsey Smith. I'm the president of the Direct Primary Care Alliance. I'm very excited to delve into the results and get those out to the direct primary care community at large.
Kenny, can you explain the process of developing and creating a survey and all the effort that went into this?
First, we had to craft the questions, and we wanted to make sure that a lot of people filled it out. So the first kind of directive was to make it short. So it wasn't like a 10, 15-minute survey nobody would do. We came together as a committee, came up with some questions. We had Dr. Rebecca Etz at VCU, the Larry Green Center, help us look it over and make sure it was legit. Then the board looked it over. Once it was ready, we sent it through the Facebook group, through email, through any network, anything that touched DPC. I'm still amazed at just how the community came together to do this. And then I had the help of Dr. Allison Hufstetler, as well as her postdoc, Shika, help us go through the data, do statistical analysis, and come out with some great numbers and insights.
We received 465 responses, and obviously that's not all DPCs, but that's a lot more than similar studies have been able to garner that have attempted this.
So 465 responses of an estimated 3,600 DPC practices. That represents about 13%.
The data was acquired over the course of a month, and Texas was always number one. There was not a single week where Texas was not number one. Florida was pretty close as well.
I noticed you asterisks, there were like 4 of the top 10 where there was no Medicaid expansion in those states. Did you feel like that was a contributor to an increase in direct primary care in those regions?
I think so. This was something that I had assumed even before the survey went out. It's like, it feels like the states that didn't expand Medicaid have a lot of DPC. And sure enough, here we are. DPC was really a safety net for this group.
Just moving through some of the results, we had dominantly female respondents.
The advantages that direct primary care offers are more appealing perhaps to a female physician, and the demands that are placed on our time and attention and just desire in how we want to structure our practice.
And I think especially in light of the fact that we are seeing more women leaving medicine at a younger age compared to men, hopefully this shows that direct care could be a viable option for those women rather than leaving medicine entirely. Most of our respondents were family physicians, but a pretty nice chunk of internal medicine physicians, and then a smaller percent of pediatricians, about 6.4%. 76% of the respondents were MDs, but a pretty sizable number of DOs, 24%.
I'll weigh in on the DO percentage. My previous partners in insurance-based care were osteopaths, and the pressures of an insurance-based practice really caused them to leave a lot of their osteopathic skills behind. I can only imagine that a lot of the osteopaths who have come to direct primary care feel a little bit of independence in being able to incorporate those skills back into their daily schedule because of the reduced time constraints that direct primary care allows. And it also allows you to put your price point where that can be adequately reimbursed.
Moving into practice ownership, the majority of our respondents reported that they were full owners in their DPC. That was 82%. About 9% were 50-50 owners, and then a very small minority were employed.
Just shows how easy it is to start your own DPC practice. Why be someone's employee if you can start a practice, with like a couple $1,000s?
Let's look at panel size. And we measured this in 2 different ways. We just asked everybody, what is your panel size? And we got ranges anywhere from less than 50 to over 1,000. But then we asked, is your panel full? And then we took the subset that was full, which was 31.6% of our respondents, and then we reanalyzed what that panel size looked like to come up with what we were calling a mature panel size. This information I thought was absolutely fascinating because these are practices that say they're full, they're where they want to be, they're happy, they're not looking to grow anymore. A sizable number of people have 100 to 200 patients, 200 to 300 patients. The trend did tend to cluster at the 400 to 700 mark. We often hear it said that a full DPC practice is 600. That is the average, but we're seeing a ton of people that are very happy with a smaller panel size. Moving into staffing, most of our respondents had a single physician, single location practice. Most DPC practices that responded did not have a nurse practitioner or physician assistant working with them. And then I was very surprised looking at the question regarding number of staff that over 30% of our respondents are running a micro practice, meaning they have no staff at all. The most common answer at about 35% is having one staff member, and then 20% have two staff members, and so on. I want to get into pricing because it was one of those huge surprises. Because for the last decade, we've been throwing around the average price point of $77 a month for DPC practice. That is based on data that came out in, I believe, 2014. And this survey found something quite different. The overall average price across the country from our respondents was $98.46 per month.
Regardless of whether you're a member of the Alliance or not, the Alliance is very grateful to everyone that took the time to participate. This report doesn't belong to just the Alliance. It belongs to the community at large to help forward the work that we're all doing. And we hope that the physicians who read this report can make better decisions moving forward and continue to advance the movement.